Khaled, are you ready? Oh, okay. Can you tell us about the case, please?
Okay, so the first case of our EUS workshop is of a 24-year-old female with no known comorbids. She had an episode of acute pancreatitis back in November with a CTSI score of 3. Currently, she has abdominal pain and on and off vomitings. Her CT scan shows well-defined peripherally enhancing collection in the head and the uncinate process of the pancreas measuring 3 into 2 into 3 into 7 into 2.5 centimeters. It is associated with peripancreatic fat stranding. CBD and the pancreatic duct are normal. Thank you.
Thank you.
Do we know the etiology of the pancreatitis?
Khalid.
Gallstone pancreatitis? जी, can you hear me?
आपको आवाज आ रही है हमारी?
आपकी आवाज
You're
आ रही
looking
है?
good today.
Okay.
You don't look like as if you've done 3 days of.
Yeah, I try every day. Nobody.
You hardly did
notices.
anything in the ERCP course, and we hopefully you'll do something here.
Yeah, that's the plan. So, here on the scope, if you can take a look, do you have a camera room view, right?
We have an excellent
Room view.
we have very good view, so you can.
And you can hear me too, right? So
Absolutely.
One thing I want to point out is like I don't know what Mustafa does or Farouk does or you guys do. I like to have a balloon on the linear too. But having said that, you can do the linear exam without a balloon. For radial, you really need a balloon on the transducer. But for linear, I like it. Especially sometimes it helps me in D2 or if I'm not having a better approximation to the wall, luminal wall, that helps me achieve that.
Khalid, Mustafa and I do that.
Okay.
Ghiyas and Farouk. Farouk doesn't routinely use the balloon on it, and Ghiyas doesn't.
Okay. So either way is fine. And with linear, you can achieve the goal without the balloon as well. So if you look at the scope, this is obviously a handle of the scope. You see the universal cord or umbilical cord. When your scope is in a neutral position and is sitting on a table, the transducer and the cord, they are in opposite direction to each other. So when you hold the scope, the way I hold it, everybody holds it in a different way. Probably they have their own way. I'm just explaining or talking about the way I do it. There may be 10 different ways to do it. Every way is right. Goal and purpose is to achieve better care, good care of the patient in safe and effective way. So the way I hold the scope is, for me, in my unit, this trolley is on my back. So I move the cord around me and it's on the back, even though the screen, EUS screen, one is here, but my EUS and endoscopic screens are right in front of me. Here the EUS screen is here, which is fine. Endoscopic is over there, which is fine too. So far, because it's not on my back, so I'm going to keep the cord right in front of me. This is how I hold the scope. What I call a neutral position of the scope is when this handle is resting on my palm and wheels are facing up. When I do that, the transducer is right in front of the scope. The way I intubate the patient is, light on kar dena zara. So the way I intubate the patient is, most people just go in and bend it like and then go it like this. That's not how I do it. Again, that there's nothing wrong with that. My favorite way to do is just like we do a oral airway. And other day, Dr. Saad was telling me that you even do a EGD scope that way too. And that is, I didn't realize I was doing that with the EGD scope as well. So what I do is, I invert the scope a little bit this way, make it like an oral airway. I go in, and for me, it makes it easier for me that I don't push the tongue backwards. As soon as I touch the upper palate, I flip the scope, and that goes around the base of the tongue right into the oropharyngeal area, and I don't have a problem with the intubation. But again, as I said, this is how I do it. So here, I try to control these wheels Obviously, if somebody has short hands, and especially in women, sometimes it's hard to control the elevator and wheel at the same time. You can use your right hand, but you're going to see that I try my best to not have to at least control most of the time, control the scope with my right hand. I'd like to control the scope with my left hand the whole time. So I will go ahead and intubate the patient gently. So now I hit the back of the palate. So from there, I'm going to flip it. As soon as I flip it, I get straight into the oropharyngeal area. And if you see that I'm just gently rotating the scope, and what that does is that lets me get through the EUS or upper esophageal sphincter. I'm already through that. One thing I did not explain that the way I hold the scope close to 25 mark, because in most patients the UES or upper esophageal sphincter is at 15 to 18 centimeter from the incisor. So I have enough scope in my hand that when I get to that I don't have to move my hand back to hold the scope again and then advance the scope through that. So sometimes if patient is not sedated well, as soon as you get the transducer at the end of the scope to the UES, they may fight with you. So here you can see the esophagus right there. I'm going through that. Other thing
Can you also see the yeah, okay, thanks.
Okay. And endoscopic,
okay.
You got that, right? I'm going
we
through,
can see both. Yeah.
Okay. So I'm going through very gently through the esophagus, and my goal is to get to the GE junction. I'm right there at the GE junction. I'm going to go ahead and suction this fluid out for a second. And other thing I want to, I don't think I mentioned that earlier or anybody mentioned that. Obviously, EGD scope endoscopy has a camera right in front of it. The ERCP scope or the side view or duodenal scope has a camera which is on the side, and you are moving forward. The way I give an example is like you are looking at the ceiling and moving towards the door. That would be a ERCP scope. For the EUS, the camera is at 45 angle, at least with the Olympus scope, it's close to 45. So you are looking at the junction of ceiling and the wall, where the corner is, where they meet, and moving forward. So that's how I give an example of this EUS scope movement and camera. So here you can see I step back a little bit away from the patient. If it's Dr. Saad or Giyasab, they can stay close because they're taller. They can hold the scope straight, even staying closer to the patient. For me, I have to step back, because every movement I do at my hand, wrist movement, I need to move it around like this, okay? So if I'm staying really close, my scope doesn't move very well. If I do anything here, that movement is not gonna get completely transmitted towards the end of the scope or at the transducer. So I try to keep my scope as straight as possible without having any bend in there. So that gives me a good control of the scope. So here, if you look at the GE junction, look at my scope position right now. What I do is as soon as I get to the GE junction, I look at the stomach, I move the big wheel a little bit towards me, and my goal is to go towards the opposite wall of the stomach. That usually is like 7 to 8 centimeter from the GE junction. So when I do that, my scope is still in neutral position. The only thing I really did is suction the air out, move the big wheel towards me. What that does is that takes me straight to the left lobe of the liver. Now left lobe of the liver is covering the whole screen. You can see that. And other thing is, I like to control my keyboard myself. I like to freeze it myself, whatever I need to. But some people, they ask their techs to freeze or press the whatever button that, press the button, whatever they need to do, which is totally fine. But for me, I control it myself. So here, you look at the left lobe of the liver, and my scope is in neutral position. Again, I went to the opposite wall of the stomach. The only thing I did is move the big wheel towards me, pull the scope a little bit back, and that took me to the left lobe of the liver. From here, what I'm going to do right now, I'm 180 degrees, just laying flat. What I'm going to do is I'm going to move the scope up to the 90 angle, and then let's see what happens. But I do that movement when 2/3 of the liver is on the left side and 1/3 of the liver is on the right side. So look at that. From here, I'm just moving the scope, keeping an eye on there, and just moving it until I get to 190. You see that? So scope is now this. Only thing I did in the same position was from 180, I brought it to the 90, and that took me straight to the aorta. Aorta position should be like this. It's a nice soft landing of the plane. It shouldn't be in this direction. It shouldn't be completely flat. And so after you find the aorta, you just gently advance the scope with the right hand. Keep that in view. You people, you can appreciate some structure here, right? That's the crest of the diaphragm. That's where I am. And I will keep moving the scope down a little bit, right and left, because sometimes what happens is the celiac is coming from the side. So here in this one, I didn't see the celiac yet until I rotate it really to the right. I still didn't see it very well, so let's see. So here it's coming off the side, right here. I will show you better in a minute. You see that now? Yeah. Okay, right here. So sometimes,
yes, we can see it.
Yeah, sometimes you have to adjust your scope a little bit. And here, when you are right on that, I'm trying to keep that structure right underneath the transducer as much as possible. You see right here, now I'm going to rotate a little bit to the right. And do you see the left gastric coming off there? Yeah. Right there.
Yes, we did.
Okay, so I'm not interested in that right now, at least. So I'm going to follow the main trunk, following that, and then you see that here, that left.
Khalid, how do you follow it?
Just gently advancing the scope and keeping that underneath the transducer. That's what I'm really trying to do. So I don't lose whatever movement I have to make. The main movement I really have to make is like just advance the scope. What that does is that takes me towards the pancreas. But sometimes what happens, which is happening right now, is the scope is getting hung up on the gastric fold. You see that? So I have to get, you have an endoscopic view, right? No. Yes. Did you have endoscopic view or no? Yes. Can you hear me?
Yes.
Can you hear me? उनको आवाज आ रही है? वो बोल नहीं रहे, बात नहीं कर रहे मुझसे.
Khalid, we can hear you and see you clearly. Khalid? Hello?
आवाज आ रही है आपको?
मुझे तो आ रही है, आपको आ रही है?
नहीं, हमें नहीं आ रही थी, पता नहीं चल रहा था. Okay.
बेटा आवाज क्यों नहीं जा रही वहाँ पे? Can you hear now?
Yes, I can hear now.
Yeah, so
okay.
There was something went wrong with the connections, but it's okay now. So you can hear us?
Yeah, I can. So this is going to be a little challenging for a normal exam. You see that big cyst there? So I really don't see much of the pancreas. It's replaced by that. But anyway, we'll keep doing the exam, and I think that's what was happening, is compressing on the stomach a little bit, and that's giving a little bit trouble. But here, what I'm going to do is I followed that celiac. I'll go back a little bit.
So you can see the pancreatic. Khalid, I was told it's a small cyst.
It's a small cyst.
And she only had pain, so I said, okay, fine, let's put it. So you can't really.
Yeah. So here you see that it's quite a bit, but I can still, let's forget about the cyst for a second, okay?
Yeah.
Okay. So here, I'm going to pull the scope back a little bit, and that cyst is also like it's if you look here, I don't know if you can appreciate that or not. This is the pancreas right here. It's kind of an atrophic pancreas. You see the pancreatic duct right here, right in the center.
And how do we know this is the duct? That's where the Doppler is.
So I put the Doppler on for that reason. And also, I can easily appreciate, I'm going to take the Doppler off for a second, and I can easily appreciate the pancreas right here. And it's not really a normal looking pancreas. Right here, this is the boundary of the pancreas right here. You see a little bit lobulation there, and you see a foci and strands. So she does have a feature of chronic pancreatitis on top of that. So here you see the duct
It's
right
a
in the
bit
center.
hypoechoic as well, isn't it?
Yeah, it's those are mainly lobules. So when there is
what I
a
meant, the lobules
fibrous tissue around the normal pancreas, that makes a lobules, and they can look a little bit hypo.
Khalid, in our experience, the Pakistani pancreas is a little more hypoechoic than
true.
You know, we've gone through so many.
Yeah, we have
It's a little bit more
talked about
hypoechoic.
that before too. So when first time I came, every pancreas looked like to me like had at least mild chronic pancreatitis, some features. But we have done so many, and we have noted that like most Pakistani pancreas look like that, a little bit hypoechogenic, and I think people are less fat here as compared to
Khalid,
our
this-
part of the world.
Khalid, this is Mustafa here. Can you just freeze the image if you don't mind, and show the candidates the scale on the right side as well as the green arrow, and just comment on those things for their knowledge?
So here, this is the really from here to here 1 centimeter depth, from here to here 2 centimeter, 3, 4, and you see this arrow. This is set up. This is what like the major gain and depth of image is up to that. So if you see anything beyond this arrow, is gonna be really, you won't get a good resolution of that. So everything which is above that arrow, that gives you a good resolution. Beyond that, there's going to be a lot of noise, and you won't have a good images of that. So Mustafa, you can add anything to that if you
No,
like.
that's exactly what I wanted to show them. And then if you don't mind, just for their benefit, just doing the depth in and out so that they can see the changes that occur
So
on the
here,
right side.
like let's keep it there. You see that how I moved it upwards, and I can move it further down, and you see that image starts becoming smaller, and but you lose a lot of resolution there.
Right.
So here, this is probably the best resolution we are getting. I can make it a smaller. It makes a little bit better resolution, but we can't see a more distal part. So I think I'm going to go back to between 4 and 6, and to Yasab's point, 5 looks like the best penetration here.
Yeah. So
Here you can see the pancreatic duct right here. This is the pancreas. This is all cyst here. Pancreas is kind of atrophied, features of chronic pancreatitis. So I'm gonna just follow pay attention to the pancreas. I'm gonna forget the cyst for a minute. So here there is you see the pancreas right there. Duct is right in the center. What I'm doing is my scope is still in a stable position. Can you appreciate that my right hand is completely free and my scope is still quite stable? So from here, only time I use the right hand when I have to maybe torque a little
Khalid,
bit
can
or
I have
push
you
the
just
scope.
pause for a second?
Yes.
Another question is being answered out here. So just give us 1 minute here, okay?
Okay.
4 centimeter, it means, and if it's 6 centimeter, so it means that we are seeing till 6 centimeter, or the same image is bigger, or 6 centimeter means that we are seeing more structures down.
You're zooming out, right? So as you're going down, you're zooming out, so you'll see more, but everything will look smaller. To look, okay? And as you go in, if you want to look at the mucosal layer, you want to go in and see with larger image so that you can see all the layers. Or if you want to see a small lesion, how do you see? How is it rising? You will be able to see that with magnified image. So So you are magnifying this when you're going in, and you're actually making it small as you're coming up.
So this means that if we want to take FNA or biopsy of a lesion, so it's better to keep it 3 or 4 centimeter. That would be clear.
4 centimeters, you see the sketch table. 5 centimeters, you see the left mistake. Now, if I can answer that further, it depends on the size of the lesion you want to biopsy also. Okay, if it's a small lesion, then you want it big so you know exactly what's happening. Whereas if it's a large lesion, then you want to have the entire lesion, then you need to have zoom yourself out and be able to see. And also the distance of the lesion from the scope. Can we
So,
go back to Khalid? Because
I think let's finish the case.
let's focus on that, and then what I would like you to do is keep your questions, and then we'll answer all those later. Khalid, sorry.
No, that's okay. I think we should, patient is sedated. We should finish the case and let me explain everything and we can answer all the questions later. Okay. So what I'm going to, so here, you see the pancreas to go towards the tail of the pancreas. I'm going to keep that duct right. And the arrow is showing the structure which I really want to see. And I'm like literally trying to keep that structure right at the arrow tip. So I'm moving the scope, whatever it takes. Right now I'm moving it to the right, rotating it to the right. And here it's not that we kind of lose the duct, but the duct is coming down here. And I'm getting really, this is all retroperitoneum. And this is the spleen right there. I don't see much of the pancreas right in here. It just ends up right there. The tail of the pancreas ends up right there. This is the pancreatic duct. We went to the tail. Now I'm at the body area. I will rotate the scope to the left, rotating to the scope to the left. You see if the scope is in right position and I'm literally not even using my right hand, looking at the screen and just following that structure. And you here is the pancreatic body. This cyst looks like in the tail area, not tail, I mean in the neck area. I follow that duct towards the neck, follow that towards the neck, and you can see, appreciate that it's coming around that cyst, and there may be even a communication in this area. So I cannot 100% comment on communication. The reason is this is a two-dimensional image. And this duct may be going around that wall of the cyst, and it seems like it may be communicating. But here, I think it really is communicating because it kind of falls straight into the duct. So here, we see that duct going into the neck. I don't see much of the pancreas. If I have go to the body and the tail, I'm just torquing the scope to the right, looking at the screen. I'm not using my right hand with the scope. I'm just gently moving that back and moving that back. Keep going. And this is the duct right here. And I'm just using my left hand to control my wheels, moving the scope back, and I'm all the way towards the tail of the pancreas. So I think this is the best we're going to be able to see the pancreas here from the stomach. And this is the body. It's all atrophied. The features of chronic pancreatitis. This is going into the neck. This is all that cyst. So let's go. I don't even see the portal conference very well, even though I think it's right in this area, but I really don't see very well. I think this is a
Khalid?
conference right here. G.
So from the body of the stomach, you can see the tail and up to the neck of the pancreas, and you can also follow it, and you can see the spleen, left lobe of the liver, left adrenal and kidney.
Yes.
So these are the structures that you generally see, and you can also see this. I know you can see the bile duct also from there, but mainly this is what you're focusing on, correct?
That is correct. Okay.
And the only movement you made was basically rotation with the straight scope.
I did move the scope back a little bit without even using the right hand most of the time, because I'm keeping a little bit traction on the scope, and I'm looking at the screen. I see where the duct is. So you need to know really, like if you have to make if you're riding a bicycle You just need to know, you know that when you have to take, if you have to take a turn to the right, you know exactly when to move the handle and when, of the bicycle. Same thing with the experience, with more you work on this, you would know exactly if the structure, what you're examining is moving to the left of the screen, you gotta advance the scope. If it's moving to the right of the screen, you gotta pull the scope. So these will come, eventually it will be registered in your mind without even thinking, you would know what to do with that. So let's go to the duodenal bulb right now. I will show you the
And Khalid, when you're doing FNAs and when you want to do other things, this becomes even more important what you've demonstrated.
exactly. So other thing is, I'll come back to the celiac and show you the left adrenal later. But let's do the duodenal bulb, and here we're going to have the same. We're going to see the same cyst, but that's fine. Let's see how many structures we can see. So you see the pylorus right there. I'm going to go into the through the pylorus. As soon as I get into the duodenal bulb, you see that compression from the cyst right there?
Yes.
Okay, so I'm looking for the duodenal apex, right? This is all cyst. As soon as I put my, let's suppose this is our apex right here, and I move big wheel towards me, and rotate the scope a little bit to the right, and you see that it's really, this is not a good case for demonstration. And this is all the cyst I see right there. And what this is cyst is doing is, it's pushing me into the D2, right? Let me go back in there. I think we may not be able to examine those structures very well because it's all covered up by the cyst. Here I won't be able to see that. I think the cyst is involving, it's very nicely walled off. It's just tempting.
It's very
to drain
tempting.
it.
I know.
So it's
I'm just holding your hand.
Yeah, Wasim is holding my hand too, and asking me to just stay away from it. Anyway, so it's a big cyst. I think we're not going to be really able to see those structures from the duodenal bulb. So what I'm going to do is, if I have a trouble seeing those from here, what I'll do is I'll let me go to the second part of the duodenum and do that it from D2. I think scope को bite कर रही है. So here you see the papilla and
Khalid, the maneuvers that you do for reaching to see the papilla or to go to D2 are similar to the maneuvers you do when you are using a duodenoscope.
Exactly. So I like to see which way I'm going, and some people it's me. It just annoys me really bad when they are in the duodenal bulb and they're just doing a movement to the left without even looking where they are going, and then they are stuck there, and it just annoys me. But many people, what they do is get to the duodenal bulb and they start doing movement to the right and try to start pushing. But I think you should see what you are doing. But anyway, here you see the papilla very nicely, even though it's a EUS scope. What I'm going to do is, first thing I'm going to describe, if you see the papilla, how to do a D2 exam or ampullary exam or uncinate process exam. Look at the papilla.
Khalid, normally you don't see papilla. Normally you don't see such nice views of papilla, do you?
It's a big cyst.
So it's actually
compressing on those areas, and it becomes very prominent. That's why we're not able to see anything from the duodenal bulb, because everything is pushed away by the cyst. So here, papilla, I see the papilla, or if you have if you don't see it well, you have an idea where the papilla is. You try to put the transducer on top of that, and I'm going to pull it back a little bit, pull on top of that. And when you do that, really, you're a little bit down distal to the papilla. You do a right and left maneuver from here. Again, we're going to have a trouble here as well, because it's all covered by the cyst. You see that?
I was told it's a small cyst.
It is small. It depends on who you ask, I guess.
Yeah. No, it was the CT scan that said that.
And no, it's really quite a large enough cyst that it's not a good exam for demonstration.
Yeah, but it may have, as we were discussing, it may have grown since the CT scan. You know, So
You are very kind, Mustafa. You are really kind.
yeah. I mean, if the CT was yesterday, that's the problem. But
No, it could have grown since yesterday. If you are kind, then stay kind. Okay. Okay. Anyway, so it's quite large cyst. I still see a little bit like this is a little bit debris in there. Some pancreas I see in this area, and I think these are the ductal structures right there. And but it's going to be really it's not a good exam for demonstration. So I think other thing I want to show you right here is this is interesting. If you look at this vessel, G,
When you're going to the right side in D2,
G.
what are you seeing and what happens when you rotate to the other side?
So when you indeed,
So this is not a good case. So if
Okay.
you want to wind it up quick, then we may be able to show it better in the next case.
yeah, that's what I'm thinking about. So let's finish it up when you are in D2. You're looking 5 structures. I mentioned those. You're looking at the aorta right in the center. If you rotate to the left from the aorta, you see IVC and right kidney. It's right kidney. And when you rotate it to the left side, you see the uncinate process, you see the bile duct and the pancreatic duct, and from there you follow that them back. So let me just come back. I think we're not going to gain much more from this case.
Yeah.
But one thing I want to do is, let's see if I can just quickly show you the left adrenal.
and then
Right.
2 things. Could you also measure the cyst if that's okay? And
Oh, yeah, I need to.
And secondly, Dr. Ras was wondering if we can look at the CT after you're done, if we have the images of the CT scan.
So it's in length at least close to 7 almost. And I think if I may have a little bit different measurements if I go to the duodenal bulb, but I think overall it's 6 by 7 centimeter.
Thanks.
Okay. So here,
How do you get to your left adrenal
yeah.
harness?
So just quickly, you get to the celiac, and right here is the celiac. You see that, guys?
Yes, we do.
Okay, it's kind of right in the center. You bring it to the center, right here, right underneath the transducer. What you do is you push the scope like 1 centimeter in and 30-degree to the right rotation. And that usually takes you straight to the left adrenal right there. So find the celiac axis, bring that close to the center of the transducer, go 1 centimeter into the stomach, rotate scope 30-degree to the right, you should get to the left adrenal. Second way to do that is you go and find your kidney, left kidney, and follow that backwards, and that would take you, and follow that towards the upper pole, and that will give you a nice left adrenal as well. With regard to quick about mediastinum, you don't have to do anything really major. Just bring the scope. Bring the scope close to 30. When you most of the time, not always, depends on patient's height. But when you are at 30, the left atrium big wheel towards you. Scope is still in neutral position. You see the left atrium right there. If you're really interested in echo, you can take a look at the valve here. This is a mitral valve. This is the aortic valve, aorta, pulmonary artery right here. If I pull the scope a little bit back, and here you can see actually a lymph node right there. Pulmonary artery, left atrium, and that's the space right there is the subcarina. So from here, if you look at my scope, it's at the subcarina. The only thing I'm going to do is make the scope start looking downwards towards patient's feet. Okay. When I do that, I get to the aorta. When I get to the aorta, I pull the scope back a little bit. Right now I'm at the aortic arch. I bring the aortic arch right underneath the transducer, gently advance the scope in 1 centimeter, rotate halfway. Now wheels are facing the patient. And when you do that, sometimes they cough because you rub their trachea. And halfway views facing the patient, and you can see that what we call a AP window, even though it's not, it's more like a little bit above the AP window. And you see that that's the area what we are interested in. Next, I bring the scope out. You can see the left carotid coming off the aortic arch right here. That's the left carotid coming off right there. This is the left subclavian right here. If you want to do a further exam, you rotate a scope a little bit to the right or left, and you may be able to see the thyroid gland there too. But you see the thyroid gland on the way on the way in. So here is the thyroid gland. You see that? That's the thyroid gland. So now I'm back into the neck, into the oropharyngeal area.
Thank you, Khalid.
So what we'll do is, I think as we go along, we can go over the stations again. Sorry about the case. It was really not the best case to show you all the stations.
I apologize, but that was based on the information.
No, it's
we had. Okay.
I'm apologizing to the trainees.